It's not that much. Okay, FAPI is more recent. FAPI is like 5 years around. But apparently the results for therapeutical indication are not so successful. And I loved what has been given by Michael Hoffman on the same Congress, ANM, the Hoffman hierarchy of theranostic. Why was iodine so successful? Because the SUV max, so the degree of uptake, is super intense. Everybody knows that. You scan a patient with iodine and you pop out. And there's nothing else in the body. The same with PSMA and dotatate. We are talking about patients with SUV, which is frequently 50, 80, 100. Very intense uptake. Super high tumor to background. What do we see with FAPI and pentaxefor? In the very lucky situation, you get to 10. So the rationale is very simple. There's not enough target to background. There's not enough radioactivity that goes there. So this area is the area where the game change will never occur. So they most likely be a failure. And again, from that same slide, well, it's super cool. Michael gifted it to me, and this technology guy, so much better than me. We can't still beat iodine. We have big hope. PSMA is a game changer. It allows early, combines and personalized therapy, but don't get crazy to select every single individual patient at the end. Doesn't make sense. And compounds with low uptake, they will not work. They will never work because the rationale is not there. So, conclusion, theranostic is fantastic. We'll love it. It's our future. What we want to see is this. By the way, this was a colleague of mine, diagnosed like 10 years ago, and then exhausted all therapy, PSA 400, treated in Heidelberg, PSA dropped down, treated again. And the good point is that he survived 4 years of great quality of life. And it was a great success. Theranostic is an approach integrating diagnosis and therapy, used since a long, long time in oncology, based on in vivo demonstration of target. There are several effective theranostic approaches already approved and widely used, and we hope for something new in the future, which is still not around. And let me finally thank my Indian friends, so from Partha, that kindly invited me here, very much appreciated. I'm so sorry that I cannot meet Venkatesh and Rakesh, which are fantastic friends of mine that I know since a very long time. And my new friend here, that was so kind. I don't know if he, oh, okay, around the corner. Great. Thank you so much. Thanks.
Thank you for that excellent overview and putting things in the right perspective. If you may allow, I would like to throw a cat among the pigeons. Go a little ahead into space in terms of the future. Do you think artificial intelligence, AI, which has been talked about, will have some role in changing the so-called personalized medicine?
I think that AI could do a lot for reading scans and also for predicting response, given the radiomics feature extraction and so on. So I'm happy with that. I think that it could work. I think it's hard that AI could work designing a new molecule. This is something that we were discussing yesterday with Professor Gambhir that was around, that told me that they are establishing radiopharmacy in India. I guess that the next step should be identifying a target and a good ligand and move forward to labeling and demonstrating in vivo effectiveness. And for that regards, AI, I don't think could be useful. But for predicting response to therapy, I would be very happy to leave it all to AI.
So another question is about dosimetry. Do you think there'll be, as nuclear medicine physicians, we are not so inclined towards dosimetry like the radiation oncologists, but theoretically speaking, it's a good concept.
It's a good concept. I'm fully with you. It's a good concept, but it's time consuming, makes the physics happy, very happy, and very busy. Does anybody ever demonstrated that the good old iodine can be better if you administer 149 millicuries instead of the standard 200. Not to my knowledge. So I'm so sorry. Let's start convincing me with the iodine, and then I will allow you to make 3 scans to my patients and multiple evaluations and so on. Because as long as it's a game you play in your lab, it's fantastic. But when you have to bother the patient, asking to come back and back again for PSMA, okay, it's an outpatient treatment, so very patient-friendly. But if the patient should come back 3 times just to have scans that nobody has ever demonstrated to have an impact, I'm sorry for the physics, if there is anybody around. But you're just, bothering the patients and me.
So, Professor Bal, effect size larger, that means placebo versus in intervention drug, so the number of sample size is less. That's the reason. And then the new concept is about 2:1. If you have got deprived a lot of people from the intervention and you are trying to use them, so it will be the patients, those who are on placebo side, they will demand why not the active ingredient. So to avoid that, so you do 2:1 ratio, which is better because it will not affect the overall survival.
Yeah, by the way, I'm not an expert of thyroid. It was just an example, but I'm fully with you. One key point is that for many years, we didn't have the big pharma behind our shoulder, and it was impossible to run a multicentric randomized trial without money. It's impossible, simply impossible. Now, apparently, there are companies willing to do that. But we cannot leave all the research in the hands of few companies, which are not there for making the benefit of the patients, but benefit of the investor. So I guess that the Australian example with the charity behind is great. And I guess that India could do something similar because, you are a fantastic country, so rapidly growing, with so much expertise in a lot of areas, chemistry, informatics, whatever. So if you give up competition, which is something which affects the Western world, I have to tell you. In Italy, there's nothing like national, collaboration. No way. It's just about competition. But maybe you can make it better. You can try to collaborate and find some national funds or some big grants to run it. Well, first of all, you need a good idea, a good molecule, a good target, and so on.
So any other comment or question? If none, then thank you, Stefano, for an excellent presentation.
Yeah, actinium versus lutetium. Actinium is fantastic because it's an alpha emitter, so it really kills every cell that it touches. There is a problem of, side effects because xerostomia is almost normal after actinium. There is also a problem of, and there are some trials, actinium is now getting to the objective of the big pharma, so there are some companies running that. Apparently, if you would need a lot of actinium in the world, there would never be enough availability. So in terms of availability, even lutetium is becoming, a sort of bottleneck. So apparently, terbium could be a solution because it's not only about effectiveness, radiation protection, and side effects. It's also about making that available. If now you have to treat the metastatic sensitive patients, then it will be 5 times more than the castration-resistant patient. So you need a huge amount of lutetium, which is difficult to be done. And actinium probably is even worse. So it's not only about science, it's also about, some sort of industrial scaling.
Thank you.
So thank you, Dr. Stefano, and I would like to thank our chairpersons. So call cost will be a determining factor, as I could understand, in all of this, apart from technology. Moving on to session 2, the FARP inhibitors, the new kid on the block. For this, I would like to invite Dr. P.K. Pradhan, sir. Sir is a professor in Department of Nuclear Medicine at SGPGI Lucknow. Welcome, sir. We are honored to have you here. Dr. Manoranjan Chauhan, sir. Sir is the Senior Consultant of Nuclear Medicine at Aditya Birla Memorial Hospital, Pune. Thank you for coming, sir. So now I would like to call all the panelists for this. Dr. C.S. Bal, sir. Sir needs no introduction. Still, sir is the Professor and Head of Department of Nuclear Medicine at AIIMS, New Delhi. Dr. Nikhil Agarwal. Sir, welcome. Sir is the Director of GI and Hepatobiliary Oncosurgery at Max Super Speciality Hospital, Saket. So, welcome, sir. Dr. Sneha Shah. Ma'am is the Professor of Nuclear Medicine at Tata Memorial Hospital, Mumbai. Dr. Somendranath Ray, Senior Consultant and Head of Nuclear Medicine at Tata Medical Center, Kolkata. Welcome, sir. Dr. Stefano Fanti, Professor of Diagnostic Imaging and Italy. And he is also the Congress He is Assistant Professor in Office in Charge at Tata Memorial Center, New Chandigarh. So to moderate this session, I would like to call Dr. Shrikant Sola. Welcome, sir. Sir is consultant in nuclear medicine and had the first spec lab and first PET city in Pune in the private setup. Welcome, sir. Over to you.
Thank you, organizers, for inviting. We are going to become wiser today with esteemed panelists. Disclosures. These slides were shared with the panelists about 48 hours ago. 20 years ago, in youth arrogance, I might not have done it, but now time has, people like Chauhan, Dr. Dhanpati, my old associate, have taught me humility over a period of time. So coming to cases straight away, we are going to show real-time cases as we deal in day-to-day practice. So 63-year-old gentleman, weight loss 7 to 8 kilograms over a period of 6 months, known diabetes, hypertension, and then some other tests were done, as you can see here, quite unremarkable. ESR was high, PSA was normal, and the reason for referring the patient was to look for weight loss. And as for some reason the FDG had either exhausted, we chose to do an FAPI scan. So that's the MIP image, and that's the regional pelvic image for the abdomen, liver. Dr. Bal, sir, what's your possible diagnosis in this case?
Yeah, it is very nice case, and I remember my third year medical student when our professor of medicine told, if there is massive weight loss in short time, there are 4 differential diagnoses. One is diabetes, one is hyperthyroidism, third is cancer, fourth is tuberculosis. So given context, there will be 2 differential diagnoses in this context. Either it will be tuberculosis or it will be lymphoma.
Okay, malignancy or tuberculosis. Dr. Ray, what is the differential diagnosis? Although Dr. Bal sir has already...
Hello. As he has already mentioned, definitely lymphoma and tuberculosis, then metastasis is always a possibility from other malignancy. Very interestingly, his ANA plot was positive for Sjogren's syndrome. So autoimmune diseases like Sjogren's syndrome, rheumatoid arthritis, SLE, sarcoidosis may be theoretically a possibility, and some other bacterial and viral infections.
Yeah, but if you look at the joints, there's nothing.
So, yeah, it's nothing.
Glands, nothing much.
But he's, you showed ANA plot was positive for
if you look at
CS, it's not there. It would be lymphoma, tuberculosis and metastasis.
So that's the IHC report for you. This was an anaplastic large cell lymphoma. Thank you for your opinion. This is a young lady with 20 kilograms of weight loss over a period of 3 months, pain in the abdomen intermittently, anorexia, etc. Montus was positive. HRT was remarkable. And the patient was referred to us for a PET scan. And for some reason, once again, I think this patient had come in the afternoon around 3 o'clock when FDG was out of stock. Patient couldn't have come next day because she was from some Mofussil outstation. And the endocrinologist said that we want to have PET now, and said, okay, we'll go ahead with FAPI. And normally what we do is if we tell them with a caveat that we do a FAPI scan, and in case we are satisfied with the result, we offer an TG on the next day without extra cost. Okay, with that in mind, we offer this. This was the MIP image. That's of the abdomen, you can see. And that's at the level of floor, at the level of adnexy, at the level of mediastinum, axially. That's the lung window. Dr. Shukla, what are the important findings?
So here in this case, we can see that there is scattered adenopathy throughout in the cervical region, the mediastinal stations, and the abdominal and pelvic regions. In the lung window, we also observe some tree inward opacities, which would indicate that there is some active infection in the lungs. So here,
what about the organs involved, likely organs which are involved, viscery, other than the lung and lymph nodes? So something in the ascending colon?
There is some soft tissue involvement in the ascending colon as well, and that would be a focus of concern in this particular patient.
So we have ascending colon, we also have adnexal involvement.
Yes.
And of course the lymph nodes and the lungs. So what is, you already described the important. So Dr. Shah, please, what is your probable diagnosis here?
The clincher here was that you already showed there's a Mantoux test positive.
Yes.
And like Dr. Bal mentioned, two important differential diagnoses could be Cox or lymphoma. But because you have a Mantoux test positive with tree-in-bud signs, ileocecal junction disease, adnexy, I would likely put towards Cox because of the Mantoux test being positive.
Yeah, so that's the histology you can see here. And it's typical of the, yeah.
Necrosis.
Yes, so this is granulomatous involvement.
Positive with ileocecal tuberculosis, that mass was actually ileocecal mass.
Yes.
So the ileocecal tuberculosis and with all this.
Yes, thank you, Balsa. Professor Fanti, is there any other entity histologically that can mimic tuberculosis?
I have to admit, I'm not an expert. It's almost disappeared in
From your experience.
But no, for sure. In general, every disease which has a granulomatosis expressed could mimic, and for us could be a diagnostic issue. I have to say, for example, sarcoidosis or even, which is quite frequent.
Sarcoidosis, of course, if there is no caseation, you could say.
Yeah, in this
But
case,
recently, the reason why I asked you this question is recently a friend of mine, his son-in-law, had lymphedema and was biopsied. And they said, very confidently, without doing it, they said this is tuberculosis. The patient went back to where he works. 4 months down the line, the lymph nodes enlarged. And then he said, instead of wasting time, come back to India. They repeated the histology, and it was nodular sclerosing lymphoma. So that is one entity which can sometimes be a misleading factor. So that's why this was from sheer day-to-day practice that we learned. So that's. Dr. Raj, would you consider doing FAPI in your patient with suspected occult malignancy? So we have a surgical oncologist.
So broadly, when we talk about occult malignancy, first of all, we have to do a complete evaluation.
That's right.
Obviously, look at the clinical picture, endoscopy, ultrasound, and
Suppose there is a lymph node in the neck, and which is positive for. And as I told you, practical, difficulties, patient's blood sugar is 500. and you have done upper GI scopy, you have done, basic workup, CT negative. Would you want the patient's blood sugar to be controlled, or you would still, having seen these cases, consider FAPI as one of the now?
Not really as of now. I mean, we do understand that FAPI is coming up as a modality, as an investigative modality, which probably have some advantages over PET at certain, in some cancers. But when we are talking about occult malignancy, we don't know what it is. And as of now, I would like to go with the standard.
Okay, I can understand your reservations, obviously. So coming to this case, a 64-year-old diabetic with fever on and off for the last 1 month, only 1.5.
Sorry, can I add just one line?
We will come to additional points later on. Let us finish up with cases in given time. So 64-year diabetic fever, and other investigations are here before you. Hemoglobin, WBC counts, liver functions were unremarkable. CRP, of course, is high, ESR is high, dengue negative, and this was for occult infection. So that's the whole body FAPI scan. Once again, patient landed up in a time when we had exhausted our FDG. Dr. Shah, is the uptake in the thyroid gland of concern?
Yes, on a FAPI you see thyroid uptake, but as intense as this. In this MIP scan which you showed, quite intense, and the thyroid appear enlarged. Since looking for focus of infection to rule out possibly something in.
So
I'm not sure whether that is the culprit, but yeah, it is significant.
Yes, so that's what, when we saw this, I called the endocrinologist saying that the thyroid appears to be abnormal. We would want thyroid functions, and he said thyroid functions are not normal, done about 4 weeks ago or 3 weeks ago. What would you do next?
Maybe a USG to look for, or a thyroid scan to look.
Actually,
yeah.
So I told them,
One
yes,
point there.
good.
If
But
4 weeks is a long time in thyroid.
yes, so that's what I said. Repeat thyroid functions, and please send the patient for a repeat or for a thyroid scan next day. So thyroid functions were repeated, and that's the result. Repeat thyroid scan is clearly thyroid function test T4 is high, TSH is low, and that's the thyroid scan done on the next day. Patients, direct questions, throat pain was present, intermittent hyperdefecation was present. So that was the established diagnosis, and FAPI was truly positive in this case. So,
From academic institution, I can see a lot of endocrinologists still believe if T3, T4 is high and TSH is low, they start immediately antithyroid drugs. Without differentiating, it could be thyroiditis. So this point, when I teach in any of the endocrine meeting and head and neck oncologist, and if you are prescribing radioactive iodine, it is the responsibility of the nuclear medicine physician to rule out that you are not treating a thyroiditis.
so this once again,
I think, can I add one point
Yeah,
to
sure.
Dr. Bal? I think this is extremely important. That's the reason the endocrinologist or any physician should wait for 6 months to prove, or you interpose a thyroid scan, which you can determine immediately and treat accordingly. That's extremely important, actually.
But I think it also depends largely upon the physician practicing nuclear medicine to sensitize the physicians and the I do not think that any endocrinologist in the city of Pune ever starts the patients on numericals without doing a thyroid
Yeah,
scan.
Dr. Sallabh, I do agree with you, but at the same time, I disagree for one point. Majority of the patients will land up with a physician rather than endocrinologist. So obviously, they start prescribing with antithyroid drug.
So physicians also need to be sensitized, and I'm sure they have learned. As a matter of fact, some of my referring physicians say that if you find that the patient has Graves' disease, do not send the patient back to me without administering radioactive iodine. They are so confident, and because many patients come from outstation, they know how difficult it is to follow them repeatedly with thyroid functions and on numericazole. And of course, it's rare though, hepatotoxicity with numericazole can be catastrophic. You all know that. So anyway, Balsar, is FAPI, coming to having seen all these cases, is as non-specific as FDG?
I strongly believe that the FAPI is an alternative or a symbiotic relationship with the FDG, but whatever the drawbacks of the FDG, the FAPI also suffers the same.
Next case, swelling in the left leg. MR spine showed thickening in the posterior longitudinal ligament, some disc bulge. MRI brain was unremarkable. You can see WBC count is high, and there was fracture of left femur. That was the reason why the managing surgeon thought of doing a scan. Once again, we landed up doing a FAPI scan in this patient. So that's the whole body FAPI scan. That's the fracture site. There's some hotspot here. There's another hotspot here. You can see osteolytic lesion. Dr. Ray, sir, what are the important findings here?
Can you just go back slide? Let me see the, yes, please go ahead. This is the fracture site is there, and there are multiple other focal FAPI avid lesions. Next slide, please. Yeah.
The question is whether this is pathological fracture or not, and if yes, what was the occult primary?
Yeah, there is see, all these are expansile lytic lesions involving the bones, and there is an exophytic lesion, I think, in the kidney. Just show me the next slide. Yes. So, which is also FAPI avid. And this may be the primary because the CT features of these bone lesions are very much consistent with mixed from RCC. And there is a lesion in.
So we have not only head of, neck of femur, but other
Yes.
we have lesions, osteolytic lesions, and of course there's a lesion here.
Right.
So, Dr. Agrawal, sir, would you accept FAPI scan in such a patient? Especially if he has, I just told you, hypoglycemia arrives late and you are interested in knowing where the occult primary is, you are interested in knowing whether this is pathological or traumatic fracture.
Short answer is yes.
Yes, so it's likely to be in the kidney, you agree?
Yeah.
So I was really very keen to know what happens to this patient subsequently. Unfortunately, he developed respiratory distress and expired. Dr. Fanti, what could have been the cause of death in this patient?
As I anticipated, I have to admit, I have no clue. And that's a lesson for the young resident there. Don't be shy to show your ignorance, because that's a good strategy to learn. I've been reviewing the case, and I admitted I have no clue.
Yeah, again coming back to the, I always teach in the nuclear medicine, we are nuclear medicine physicians. Whatever you practice, you should not forget medicine. Without medicine, if you do nuclear medicine, you will be a, and very blunt, I say it will be photograph. If you have got a lytic bone lesion, the cancers which are number one is renal, thyroid, and lungs. And if you can see there is a mass in the kidney and there is a lytic lesion, this is 2 + 2 is 4. You just make it that. But the commonest malignancy in the kidney is the clear cell RCC, which is not FDG avid. But the papillary carcinoma of the kidney and the sarcomatous variety of RCC, they are very, very malignant.
Question is,
that is why they
what could
very high
happen?
FDG.
Question is, sir, what is the likely cause of death in this patient?
In these days, because the disease itself is very aggressive.
Sorry?
Embolism.
So whenever a patient, this is one very, very important message. Whenever a patient, your technologist comes running to you saying that, sir, patient is dyspneic, we are dealing with malignancies, never ever ignores the possibility of pulmonary embolism. You have such high prevalence, and it's a treatable entity, and it can be prevented, if we are vigilant in our practice. And we have seen these cases happen, so potentially treatable. So I question that came to you, sir. How good is FAPI for RCC?
I have already answered that. In clear cell RCC, which is constitute about 70 to 80% of the renal cell carcinoma, the FAPI is very bad. But all other rare conditions of the kidney, malignancy, the FAPI is positive. So the FAPI positive in RCC indicates bad prognosis. It is better than FDG.
Dr. Somin, you want to add?
Yes, the chromophore variety of RCC. Here, FAPI worked better than FDG and other tracers. So it has been reported in the literature. Chromophore variety of TXLC of kidney, where FAPI works well.
Okay.
Variant of kidney cancer, it's different from clear cell renal cell carcinoma.
Right.
Okay.
Mine is positive in clear cell RCC.
Okay. Going to the next case, this is a 72-year-old lady with ultrasound showing hepatomegaly, multiple liver lesions, suspicious of metastasis. There were some abdominal nodes. CA199 is normal, CEA is normal, CA125 is also normal. Biopsy from liver lesion shows metastatic adenocarcinoma. And of course, the purpose was to look for occult primary. So that's the FAPI scan, full body. That's at the level of pelvis, at the level of abdomen, the node here, at the level of liver. Once again, liver. At the level of, this is the coronal view. So Dr. Shah, where is the likely primary in this proven metastatic adenocarcinoma?
In this picture, what you're showing, there seem to be liver lesions and colon uptake and retroperitoneal nodes. With a metastatic adenocarcinoma as your histopathology, the colon would be the most likely differential primary site of primary disease.
So what would you ordinarily ask your, referring consultant as a next step? Would you ask for colonoscopy?
Colonoscopy.
How often does a medical oncologist say that we have imaging evidence of malignancy, we have metastatic disease, we straight away go ahead and start chemo? It's so frustrating sometimes, when you call back the medical oncologist or the managing physician, what's happening about the colonoscopy, and they say, we know that this is metastatic, and we have put the patient on chemotherapy straight away. Does it happen with you?
No, we
In your institute, you can afford to say that, no,
we need to have outcomes to differentiate.
I'll see from liver.
I didn't see that. I just said
Yeah, but in this, I'm not talking about this particular case, but it often happens that when you want to follow up such case, metastatic liver disease is proven. We have done imaging and which shows a primary site. And you call back asking whether scopy has been done, and many times they say that, okay, we have proven metastasis and we start the patient on.
No, I doubt anybody.
In this case, there are two differential diagnoses. Either it is arising in a 72-year-old, arising from the ovary or from the colon.
But ovaries are negative, sir. This is only the uterus.
CA 125 is 3, normal is 35, it is 125.
No, sir. CA 125 is 7.1.
7.1. What is the word 35? What is that?
Everything is normal, sir.
I doubt anybody would go ahead.
So what you can do, what we want to know in the CA colon, we want to know whether there is a mutation, whether EGFR is present or BRAF mutation is present. So direct the drug. In that case, if you take any biopsy from the liver or any suitable site and do the mutation analysis, and then you know the Ki67, you can start the treatment.
So it's possible with the liver sample as well. That's what you're trying to say.
It's not necessary you have to go to the primary to do that.
Yes.
In fact, many a time, the primary will have less mutation burden, but the metastasis will have more mutation burden, because metastasis has to grow in an environment which is hostile. So the cancer cells have to mutate themselves for their own advantage. So the mutation burden in the metastatic deposit is much more higher than compared to the primary.
Thank you, sir. So, after having addressed this question, is uterine uptake a deterrent in women for performing FAPI?
Yes, it can be, because normal uptake is seen in uterus.
As is seen in this patient as well.
And it also depends on the cycle as well as the age of the patient. Premenopausal would have intense uptake.
But does FAPI have variable uptake in uterus as per the patient's age? I doubt.
Yeah, there
Does
is during the cycle. Does vary. Premenopausal women would have better uptake as compared to postmenopausal. In postmenopausal, you might be able to pick up disease if it's basically
This was a postmenopausal actually.
turnover of the cells. FAPI is taken up in tissue which is having turnover. So a menstruating woman where the tissue cells turnover, there you will have increased uptake.
Dr. Shukla, known metastatic adenocarcinoma, FAPI shows liver deposits, retroperitoneal suspicious ascending colon. Would you like to perform a FDG in this patient? And if yes, how will it help?
If this case, if our scan was indicated to find the site of primary, then FAPI has solved its purpose. And then further workup using colonoscopy and
as your colleague said that this is a postmenopausal woman and the uterus is also showing uptake. There's uptake in the ascending colon as well. So, of course, doing an ascending, colonoscopy would sort out this issue. Okay, going to the next case. This is a surgical point of view. Weight loss of 2 kilograms in 2017. CTs revealed GB calculus, circumferential thickening in the GB neck, narrowed CHD, that is common hepatic duct. And MRCP revealed dilated intrahepatic biliary radicals, confluence of radicals not seen at hilum. ERCP tight stricture while passing the sphincterotome across the hilum. Cytology was negative for malignancy. That's the MRCP in 2017. MRCP. And around the same time, an FDG PET scan was done. And that's the FDG PET in 2017. So after this, the patient was put on conservative management, nothing much, developed 2 to 3 episodes of cholangitis, treated with antibiotics. And in recent months, the patient had rise in gamma GT. With that history, the patient came for a follow-up PET scan. So Bal sir, with this history of recent rise in gamma GT, what could be the reason for a follow-up PET CT scan in this patient, which the oncologist might have thought of? And which molecule would you choose for doing a PET scan?
Yeah, gamma GGTP increase is only sign of obstruction only. Just like say alkaline phosphatase, you see gamma GGTP, it is rise in the obstruction, and you have already told there is a stricture in the lower end of the CVD.
It's actually sclerosing kind of cholangitis picture.
So the MR picture was is very sclerosing cholangitis, was very, very much clearly seen. And one of the differential diagnosis you should always remember is a cholangiocarcinoma.
Exactly. So with that in mind, he was sent for a follow-up scan, and we said this time we'll do a FAPI scan. And that's the FAPI for you. Except for, because there was nothing, there was no malignancy. FDG PET also was quite unremarkable. There was nothing there except for MRCP showing evidence of sclerosing cholangitis. That's about it. He had few episodes of cholangitis which were conservatively managed with antibiotics. That's about it. I don't, let me see his reports. Let me see his reports. No, I don't remember, but I think there was mild jaundice which was effectively treated. Okay, so this is a follow-up FAPI scan. And Dr. Ray, what are the findings here?
Yeah, so if you see the MR and the FDG PET and the FAPI, so as you have already documented that in MR there were dilated IHBRs, and very interestingly FDG PET showed there was increased uptake in the initial scan along the course of the dilated HBR, again suggesting cholangitis. And coming back here, this with the gamma GT raised means it's some sort of chronic liver disease involving the parenchyma, and the FAPI showing diffuse uptake involving nearly the entire right lobe and most of the parts of the liver parenchyma. So suggesting.
So except for this segment,
Yes.
this segment, almost everything.
Yeah, everything. Probably segment 4 is spared. Everything is involved. So it's parenchymal inflammation grows.
Yeah, Balsa, any comments?
This cholangiocarcinoma is FGF1 receptor dependent. And the FGF1 receptor dependence, now we have got 3 FDA approved drugs. Infigratinib, there is all tyrosine kinase derivatives. Then we have got pemigratinib. We have got one more in the process. There are 3 FDA approved drugs, which is the fast track approval for infigratinib, which is now being used for cholangiocarcinoma because there was no treatment for cholangiocarcinoma. So the FDA approved in the first track and got it approved. And because they are FGFR, there is fibroblast growth factor 1 is the overexpression, and then we have got fibroblast growth factor receptors involved. So FAPI is the modality of choice for cholangiocarcinoma.
Actually, there wasn't much of uptake on the initial FDG scan except for this linear uptake seen over here. There isn't anything, sir. Quite unremarkable, quite normal scan.
There was no focal uptake.
This? Where is it? Nothing there, sir. Absolutely. It was a normal FDG scan.
Yes, sir.
What I called always, these are the dots and marks on the PET scan. So it should not be given because the PET scan itself very sensitive. Don't make it super sensitive.
So quite unremarkable, actually. So coming to surgeon now, is there anything to offer to this patient with sclerosing cholangitis and recurrent cholangitis?
So, I mean, what is the interpretation of the current scan?
This is sclerosing cholangitis diagnosed with intercurrent episodes
I mean, the last scan which you showed, this is cholangiocarcinoma, intrahepatic cholangiocarcinoma.
No. It is just diffuse inflammation of the pancreas.
There is no malignancy.
No, there is no malignancy here.
Okay. So, I mean, generally sclerosing cholangitis is treated with transplant. There are no other surgical options. If you have a dominant stricture, you can do a bypass, but generally the treatment for sclerosing.
There's nothing else that you can offer to this
else
patient. Okay. Well, sir, would you like to offer any other test for this patient?
In cholangiocarcinoma, unfortunately, nuclear medicine is blind.
But we are not suspecting cholangiocarcinoma anyway. Is there
for sclerosing cholangitis also, for this sclerosing cholangitis, like any other inflammatory condition, we give steroid, which is non-specific.
So, regarding sclerosing, what percentage of cases of sclerosing cholangitis can lead to cirrhosis of liver or chronic liver disease?
Yeah, this is apart from the alcoholic and hepatite, the viral, the cryptogenic, and the fourth and least amount is cholangitis. Sclerosing cholangitis producing cirrhosis is very little. So the commonest one is of course.
Of course it is, but one of the differentials is
very less. So when we do the bottom line in the footnote, that comes.
Yeah, that's right. But it's one of the rare causes. So to rule out chronic liver disease, what else can be offered is colloid liver scan. We should not forget about it. So this was of course ruled out on colloid liver scan. Dr. Pandey, what tests do you consider to rule out chronic liver disease in your institute? Or is it a forgotten science?
I have to tell you that I'm positively surprised of how many nuclear scans you performed in these patients, because my relationship with the liver unit is that whenever there is some liver disease, they don't even consider to call me, but it's all about radiology. And it's all about MRI, and in case, contrast enhanced ultrasound. So my relationship with the guys in charge of liver is non-existing.
For chronic liver disease, how often your physician or gastroenterologist considers colloid liver scan?
Never.
Used to do dozens of them when I was training with Dr. Lele, if you remember, long back. Okay, this is an interesting case. 18 kilograms of weight loss, 3 months, over a period of 3 months. Raised echoes on renal ultrasound, diffuse fatty liver, bilateral renal cyst, PSA is normal. You can see here other other investigations are quite unremarkable. In the past, there was some history of surgery over the forearm for what was a locally invasive spindle cell tumor, and the referring doctor categorically said, I am not suspecting metastasis. I am suspecting some other malignancy because of severe weight loss recent past. So that's the CECT, which was done before the patient came to us. That's the MRI, which was done after the CECT. And do you, Dr. Bal, do you find CECT or MRI to be abnormal in this patient?
The difficult question. Of course, I can read the MRI. There is a lot of fatty liver, and except the left lobe, the whole of right lobe is started with fats. So that cannot explain 18 kg weight loss.
So much of weight loss, 18 kilograms of weight
18
loss.
kg weight loss in short span of time has to have malignancy.
So what next, sir?
What can I should do to find out? You mean
What would you prefer in a patient with suspected liver FDG or FAPI, liver malignancy?
Of course, the universality is to do the FDG, and if FDG cannot give me answer, I have fortunate to have FAPI,
Good,
not
sir.
for
So
diagnostic,
you
for
said-
therapy also.
You said FDG, we did FDG. So look at the FDG, sir.
Nothing.
So we have FDG, we have MRI, and we have contrast CT with you.
Yeah. Nothing has answered you.
Doctor. So having witnessed the preceding cases, Dr. Agrawal, sir, what would you like to order in this patient where FDG is or as confusing as CT or MRI?
Can you go back to the previous CT? I want to see CT scan. Yes. You see, there is something there. You cannot see things. You cannot ignore the findings here in the CT. There is something like a mass on the left side.
Yes.
Right. And if you have a CT or an MRI like this, I would start looking into the resectability, whether my right artery, right vein are free. And if they are there, I would stop my investigation. Then I would offer surgery to this patient. We don't need to investigate further.
All right, sir. Now, if I show, sorry, this patient is 74-year-old. 74.
Normally, left lobe and unique feature is lamellar, which is the lamellar variety of HCC, which is very seen in very young age. You can see in their second decade or third, and then you have possibility is the other one. If you exclude the cholangiocarcinoma, if you exclude the lamellar variety of HCC, the other one is cholangiocarcinoma.
So, what percentage of patients of lamellar variety or well-differentiated hepatocellular carcinomas are falsely negative on FDG?
There, the
Large number of patients, Dr. Agrawal, large number of patients of well-differentiated adenocarcinomas are falsely negative on FDG. That's the point of showing this case. We did an FDG. We were not at all convinced with this. So we offered a FAPI scan on the next day, and look at that, sir. And look at that.
lobe was fatty, and the left lobe is carrying the disease. And
Agrawal, sir,
you checked it with the FAPI and you got this.
Look at that, sir. Yes, sir. Look at that. But look at the difference between FAPI and FDG, sir.
Yeah.
So, Dr. Agrawal, are you still not convinced that FAPI could have?
I'm convinced, but like when we are talking about patient treatment, we have to zoom out a bit and see the overall picture. Now, see what we are going to do to patient. Either we are going to operate or we are going to offer some form of palliative treatment. Now, if I've done a CT scan, it shows me some mass. If I can operate, I operate. If I'm offering palliative treatment, I need a biopsy there. Right? So I either do a biopsy or I operate. So I can't keep on doing investigation after investigation just for the sake of satisfying my curiosity.
Look at the margins of the mass between.
I hear
Yes.
might give me more information.
Look at this.
More appealing.
All right, sir.
In cases like, say, for an example, if we talk about FAPI, so adenocarcinoma of stomach, especially the signatory, we know that PET-CT and FAPI has some advantages. If I'm offering first investigation and if my institute has FAPI, I might order FAPI, right? But then, I mean, doing FAPI after a PET
So
scan, after a CT, after a MRI.
from the initial statement of I would not consider FAPI, I might consider FAPI. I think we made some point here. Anyway, Dr. Nilendu wants to say something.
The capsular attraction.
That's true. That is true. Fine. Agreed. Agreed. If Dr. Nilendu, purpose of PET scan is always for metastatic workup. If FDG is negative in the primary, what percentage of metastasis will be positive on FDG? Unlikely to be. You want to have a scan. You want to look at this scan. You want to have this preoperatively to have your margin, resectable margin, which is fairly away.
You must remember, it is 10:1. The liver is the home for all the metastases, and the primary liver tumor is much less compared to the. So whenever you see abnormality and you see the liver is abnormal, first thing is made.
Sir, 5 seconds. We have 5 seconds. We want to finish inside the bell. Look at that. That was operated upon, Agarwal sir, and that's the cholangiocarcinoma. Thank you very much all, because we are in time.
Why not biopsy first?
Sorry, yes.
Time is over, but I am biopsy. You do investigation.
Sir, it's not a question of we want to do metastatic.
Biopsy you can do when there is a clear-cut lesion.
Is to inform, what is behind. Margins were so ill, evidence of, so
Dr. Slav, I think it was well pointed out that the additional investigation is not encouraged. If you find something at the CT, even I saw the CT, there was abnormal.
We have to know the limitations of FDG scan, which is what was pointed out in this case. We showed that the tumor was localized and it was well demarcated, and it was pre-operatively. The patient has almost been cured. I mean, it's cured.
I think for the house and audience, this is just to demonstrate the addition. I think
FDG and with FAPI we can almost cover 90, 97, 98% of the cancers. That's the message. When FDG doesn't work, the FAPI will work. When both will not work, unlikely we will get the diagnosis.
Thanks, Dr. Sulabh. Excellent cases that you have demonstrated. And it definitely enlightens the audience here also about the additional value that FAPI can give in some cancers, especially in hepatocellular carcinomas, hepatobiliary, and particularly the pelvic related diseases in females. It has a new role to play, and in future maybe it will open a new door for theranostics. That let's see, the time will tell us. Thank you.
Thank you.
Thank you, everyone. So the next lecture is on oligometastatic carcinoma, prostate biology and trials by Dr. Hussain Jadwar from USA. Welcome, sir.
Well, thank you very much. There was a change in the schedule, so I'm gonna, and I promised Dr. Swagat Dash that I'm gonna do it in 15 minutes. So hang in there, we're gonna go really fast. We talked about oligometastatic prostate cancer. By the way, that was a very interesting debate just before this. So what I'm going to do is this is the outline very briefly on the biology of metastatic disease, history and definition of oligometastatic disease, what it means in prostate cancer, some of the clinical studies that are done or being done, and some case examples and some of the pending issues. So this is a very nice paper. I think if you have a chance to look at it, this basically talks about the biology of metastatic disease and really thinking of it as a spectrum theory rather than binary. So in other words, it's just not yes or no. You can have low volume metastases which are different in the biology from high volume metastatic disease. And there is a lot of spatiotemporal heterogeneity that occurs in the primary tumor. And the primary tumor tends to send these metastases in a very heterogeneous way at different times. So the bottom line, the message is that not all metastatic diseases are clinically equivalent, and they're very different from each other. And we need to really find what's called the index mets. Those are that are very bad and culprit that cause major problems. If we can some way identify these index mets and try to take care of them, maybe we can have a better outcome for the patient. So this is the same paper again, and some of the other messages I wanted to convey in here. And what was interesting is that they did tracking of these metastases and from the primary tumor to different sites. And it turned out actually what we sometimes on imaging, for example, call local recurrence. It's really not local recurrence. It's metastases that comes into that same site that we operated on or treated in the initial time. And that is actually a metastatic disease, not local recurrence of the tumor. Now, there is some evidence that, especially in patients with low volume metastatic disease, there may be benefit to remove the primary tumor. So, for example, does it make sense to do radical prostatectomy in patient who has de novo metastatic disease? If it's a low volume metastatic disease, that may actually make sense. And the other message is that this TP53, the tumor suppressor gene, is the culprit. It's almost involved in half of all metastases in prostate cancer. Major problem. These are three different patients, patient 1, patient 2, patient 3, and through tracking all the genome in these metastases, they were able to find out that, for example, this metastases in C, or I'm sorry, in the primary tumor C, was going to different nodes in here, and then that node send a metastasis all the way up to the bone up there, and then from there you have this bone met kind of send another metastasis somewhere else. So there is a lot of communications between these metastatic sites and the seeding of different places. Very interesting finding. The other finding here is that the genomic landscape of metastases during the natural history of prostate cancer is really gets worse and worse and more heterogeneous as you go on from local primary tumor to polymetastatic disease. So, for example, in biochemical recurrence, there are some genetic abnormalities, but not as much as oligometastases. Then the polymetastasis is worse than oligometastasis. And then in patients who have de novo metastatic disease at the time of initial diagnosis, they are the worst. They have a lot of heterogeneous genomic landscape. I showed you this before yesterday, so I'm not going to dwell on it, but just to show you that there are oligometastases that you can see at the initial phase. This is called synchronous or de novo oligometastases, and they're amenable to metastatic directed treatment, usually through radiation. Metachronous is in the middle section, biochemical recurrence. And finally, we have oligometastases, which are called induced or oligoprogressive or oligopersistent. These are metastases that remain when the other metastases get better and treated. Now, although we all call them oligometastases, but please remember that the biology of these oligometastases are 100% different from each other. They are completely different animals. Now, this is another way of looking. This is total tumor burden in the patient. As you can see, different areas: primary tumor, salvage therapy, oligometastatic disease that eventually turns into a polymetastatic disease and goes all the way out to the terminal event. So we have these episodes of differing tumor volume. This was actually another very interesting study that's showing that when you, as time goes on, this is the axis in time, as time goes on, these metastases which come in here, some metastases may just die. either on their own or with treatment. But some may not. They actually go on and become polyclonal and then cause these other metastases. Again, some may die, some may survive and then go on. And you have this tree of all these metastases that develop over time. And as they go over time, they get worse and worse and become a lot more heterogeneous and a lot more virulent in their potentiation. So what is the oligometastatic disease? It was proposed by Hellman and Weisselbaum back in 1995. The idea being that these oligometastatic disease, these are low volume tumors. They are amenable to metastatic directed treatment. And I already defined these things. And you should approach them differently than you do with polymetastatic disease. Now, there's a lot of names that goes on with this. I'm not going to go through all these definitions, but please remember that some of these are similar to each other, but you have to kind of look at this paper and see what these all mean with regard to just definitions. What are the what is the definition of oligometastatic prostate cancer? That is really defined at this time by imaging. This was a consensus, and they said that if you want to look at oligometastatic disease, you really should do PSMA PET-CT because that's the most sensitive test that we have. And then there was also a consensus that oligometastatic prostate cancer should be defined in castrate-sensitive phase of the disease, and it should be only 3 to 5 Mets in maximum of 2 organs. That's the definition. There was a consensus regarding, or there was a survey that they asked physicians, what would you consider a success if you treat this oligometastatic disease? And they said that if you can keep my patient ADT-free, androgen deprivation treatment free, after you do the MDT of oligometastatic disease, at least 1 year, so that I don't have to give him the drug for 1 year, that would I consider a success, 1 year or more. And then cure rate, again, they said if you have the cure rate of somewhere around maybe 10% or 15% or more, then I would consider that worthwhile. So this is what their thinking is of what is worthwhile. Now, you should, again, as I mentioned already, oligometastatic prostate cancer is really a different animal. It's biologically different from polymetastatic disease. There are ways to try to see if they can see the difference from non-imaging point of view, and one is called microRNA, and it turns out that the microRNAs which are only just bunch of nucleosides from these tumors, that seem to be different between oligometastatic disease and polymetastatic disease. And so we really want to investigate this more, that is it worth it to take out the primary tumor, for example, do radical prostatectomy, when you know the patient already has metastatic disease, and that is being addressed in some of the trials like Stampede. This one also, they said, this was a con. They're saying that they didn't believe that all oligometastatic disease is different from polymetastatic disease, but it really depends. Depends on the type of the tumor you're talking about, especially the tumors that are very aggressive from the very beginning, like Gleason 8 or above. They tend to be very similar to each other, but from an earlier phase, they tend to be completely different from each other. There are a number of clinical trials that have been addressing this. I show them, some of them to you. Some of them are not necessarily just prostate cancer. They are also looking at other cancers. But the ones that are prostate cancer is, for example, this one is a STUMP. That used choline PET-CT with the definition of 1 to 3 Mets as oligometastases, and they did metastatic directed treatment, and when they did that, there was better outcome for these patients compared to the patients who were just on surveillance. But it very interestingly, about 35% of metastases, they just spontaneously disappeared on their own without any treatment. And then in the MDT arm, 30% progressed even though they were treated. So you can have both sides of the coin. Here's another trial called PopStar. This uses the sodium fluoride PET-CT with a definition of 1 to 3 bone mets. And when they did those metastatic directed treatment, the 2-year freedom from ADT was about half of the patients. So that Oriole is another trial, where phase 2 trial. This was using conventional imaging for finding oligometastases, 1 to 3 mets. And it, again, if they treated, even with conventional imaging, which is not as sensitive, they had better outcome with metastatic directed treatment rather than observation. So even with conventional imaging, that may be worthwhile. There's another trial called OLIP. This is a phase 2, less than 5 mets, but this was using PSMA PET-CT, and it turned out that about a quarter of the patients had free of PSA progression at 3 years if you treated them with metastatic directed therapy. Now there is a trial called going on right now. It's called Bullseye. Initially they were using PSMA INT, but there's an update very recently. They changed it to PSMA 617, basically the same as Pluvicto, and they're trying to see if they treat this oligometastatic disease, if there is advantage in outcome in these patients. Again, using PSMA with up to 5 mets. There are still more trials going on. There's a PIS5, Indicate, Presto, and Pilar, and you can see what they're using as the imaging agent, PSMA here, choline and PSMA here, fluocinolone here, and choline and PSMA and fluocinolone, all of them in that, whatever is available. And these are the outcomes they're looking at. So a lot of exciting information that we should expect in the near future. This is also another interesting study showing that when a patient is receiving ADT on top of metastatic directed therapy, they tend to be doing a little bit better with regard to radiologic progression-free survival. But also at the same time, the idea is to delay ADT as much as possible. So that needs to be worked out. Just show you some examples. It's a patient, PSMA PET scan. There's a node in here and a lesion in here in the bone. It got treated with radiation. PSA went down from 11 to 0.2. Here's another one, metastatic directed treatment. A node in here, very small node, got treated, and PSA went down from 0.5 to 0.3, did well. This is unfortunately because the patient had a node and it was treated with metastatic directed, and well, 2 nodes, the 1 node, 1 lesion, 1 bone lesion. They got treated with metastatic directed therapy, but unfortunately, although that got better and that node went away, but there was a new lesion now in elsewhere in the bone. So you fixed 2, another one came out. This is the same issue here. 1 lesion in the bone that got treated with radiation, which you can see the difference. Unfortunately, 2 more appeared after that. So we can't predict those. So we don't know why this is happening. We have to do more studies. This is another interesting case using C11 choline. There was some lesions up here. The patient received docetaxel and the PSA went down from 14 to 10. Unfortunately, the scan wasn't as good. Then they gave him abiraterone. PSA went down further, and some of these lesions got better, except this guy. So this is what we call an induced oligometastasis. You had multiple metastases in the past. You took care of them, but one is just oligoprogressive. It's just staying there. It's very stubborn. It doesn't want to go. So they started radiating that, and you can see it got better. PSA went down to 1. So this is what we really call precision oncology that was talked about by Dr. Fonti, that you kind of see what's going on, and as time goes on, you kind of adapt your management to that patient. This is my last slide, I think. So there's a lot of interest in this area. We need to still have a standard definition for oligometastasis. Right now, different trials are having different definitions, but up to 5 mets, not really more than 5. It depends on highly depends on the performance of diagnostic imaging tool. That's why the consensus was to use PSMA PET-CT, because that's the most sensitive. But it should really be biomarker driven, either through imaging or through non-imaging ways, like the microRNA that I mentioned earlier. And so is there a way to really see the difference in biology? Maybe in the future. And the hope is that we can really intervene in an intelligent way as time goes on, so to treat the patient. And again, this is an exciting area. And I think this is the last slide showing you essentially what I just said, that you can put the patients into 3 volumes: high volume, oligometastatic, low volume. You can do like liquid biopsies, you can do circulating tumor cells, you can do microRNAs, you can do a lot of things, and trying to understand the biology and put them all together with imaging and hopefully even use AI with big data processing to see what is going on. These are the remaining questions. Will a strategy of metastatic directed therapy of oligometastatic disease, either with or without additional systemic therapy for micrometastasis, which we cannot see, does that lead to risk decline of metastasis to metastasis seeding? I showed you the map, because we want to prevent that. You don't want this metastasis go to the other place. Is there a meaningful delay in the natural history of prostate cancer? Does that improve disease-specific overall survival? And the bottom line, should we really do this? Should we catch them all or not? So we don't know yet. So hopefully those trials that I showed you will really tell us what to do next and how to approach this very interesting issue. Two papers that I suggest that you look into. This is a Lancet Oncology published, it's a consensus recommendation from the European group regarding oligometastatic disease. And these are my papers that were published in American Journal of Radiology and JNM regarding this oligometastatic issue and what are the things that we need to think about. And with that, again, I acknowledge my funding, and here's a University of Southern California campus, and my office is right up there at the medical campus, and as they say at USC, fight on. All right, thank you so much.
Good morning, everyone. So let us begin with the third session of the day. And the topic is Roadmap to Precision Molecular Imaging. So I would first of all like to have the privilege to call upon stage the chairpersons for the session. Dr. Rajesh Kumar, Professor, AIIMS, Jodhpur. Dr. Ambhiranjan Santra.
To present what we have brought to India. So as Medica Bazaar, we have brought all high-end technologies, including digital PET-CT, digital PET-MR, digital SPECT-CT, and a full range of cyclotrons from advanced cyclotron systems. And through our collaboration, we will be getting most probably our first cyclotron at AIIMS Delhi. We have currently about 26 installations of digital PET-CT in India, including UMI 550, UMI Vista, and our first digital PET-MR also at Omega Hospital, Hyderabad. Overall, we have about 50 orders and about 90% market share in digital PET-CT. Looking forward to making it even higher with your support. The next future is by next July, we will be bringing a full range of linear accelerators, which includes a CT LINAC, where a LINAC treatment head is mounted on a dedicated diagnostic CT. It's a full diagnostic CT, so all RT planning and treatment will happen on the same patient bed. And we'll have a dedicated linear accelerator also with all ranges of energies, just like what other vendors have right now. So we'll have full gamut of products starting from diagnosis to therapy. And we'll have cath labs also, the robotic cath labs, as well as all floor mounted, ceiling mounted, full range of cath labs by 2024 year end. So we'll complete the complete imaging portfolio. Just a brief about the cyclotron range of ACSI from 19 MeV, 400 microamp, and having a variable energy capability. All other cyclotrons in the industry are fixed energy. If it is 16, then 16, 18, then 18, 30, then 30. This range of cyclotrons is completely variable energy. It starts from 12 to 19, or 15 to 25, or 12 to 30, 15 to 33. So if you want to produce PET radioisotopes, then we have TR19. If you want to produce SPECT radioisotopes, you have TR24. If you want to have a very high yield, up to 1.6 milliamp, which is 1600 microamp current, of both PET and SPECT radioisotopes, then TR30 is the right choice. If you want to produce all these isotopes that a TR24 and a TR30 can and have a small footprint, then you have a TR Flex with a current capability of 800 microamp, which is like a TR24. So coming to the latest breakthrough in molecular imaging, which has broken all barriers, is UMI Panorama. This product we launched in US and now in ENM, and now first time discussing it in India. So this has broken all barriers that we were thinking earlier of time of flight, the resolution and everything. So just basics on what specs it has. So there are two options starting from 28 centimeter to 35 centimeter. So 3 to 4 beds, complete patient can be scanned. It has the highest NEMA resolution in the industry, which is 2.9 mm. 194 picosecond, breaking the 200 picosecond barrier, and 500 kcps NECR, 76 centimeter axial FOV, completely different range. Whatever products we have right now, UMI 550, UMI Vista, UMI 780, and the total body PET, all are 70 centimeter. This is a completely new CT, which is 80 rows, 160 slice, 100 kilowatt generator, very powerful, and the fastest rotation speed of 0.25 second. 0.25 second in itself is a very high speed, if you consider even a start till the processing. And it will actually take molecular imaging in a completely new direction. So if the uniqueness of United Imaging is that everything is in-house, starting from growing the crystal to cutting of the crystal, designing, manufacturing, R&D, everything is in-house, both PET and CT detectors. So whatever happens, everything we can maintain a very high quality. Most of the vendors have their suppliers which supply as per their specifications, and hardly, other than assembling, anything is in-house. With United Imaging, everything from the microelectronics chip to the growing of the crystal to the cutting to designing, everything is in-house. So in COVID, if you see, there are a lot of supply chain issues. United did not have any. We have our separate company called United Imaging Microelectronics, which manufactures chips. We have a separate company called United Imaging Artificial Intelligence, which makes AI applications for all modalities, which is CT, MR, PET, everything. So we are the best in terms of AI as well as the quality of the crystals that we grow. We are able to achieve the highest resolution in the industry. A very unique proposition for this PET is application-specific integrated circuit. It's a completely new technology of crystal and SIPM, which ensures 100% coverage of SIPM with the crystal. Any PET available in the industry does not cover 100%. You can check what they cover, but no one covers 100%. And the FOV is extendable up to 148 centimeter. And in the same platform, we already have a product called Panorama GS, which is 148 centimeter. Right now also you can buy a 148 centimeter Panorama in the same platform. And anytime when you buy a 28 or a 35, you can upgrade to 148 centimeter, which will enable you to do 1 minute head-to-toe scanning. The CT, as we discussed, is the highest end available in the industry with 0.25 second rotation, very low dose 60 kVp scans. So most of the CTs scan at 80, 100, 120. So for patients who may be doing repeat PET exam, this will be very important, or maybe pediatrics, sometimes when you need, it will give you very, very low dose. And this is the first PET CT with dual energy capability. If you want dual energy in CT as such also is used for oncology applications mostly. So when you want a dual energy in the CT for oncologic imaging, you can have a dual energy in the PET-CT CT itself. So for any purpose, whether you want to do a high-end coronary angiography with heartbeat more than 100 or 110, 120, you can do it with very high confidence without beta blockers most of the time. And when you want to do a dual energy scan to give you extra information, you have that as well. So this is a no compromise CT, completely taking molecular imaging to a different level. And if you see all specifications are top notch. So you get small lesion detection, lower image noise, very fast scans, in most of the scans in 3 to 4 minutes maximum, better image SNR and clarity. So you have highest timing resolution, sensitivity, high axial FOV from 28 to 148, and very high spatial resolution. So as we earlier also discussed, with the complete manufacturing happening inside UIH from designing to everything, we are able to produce this unique technology of the PET and the SIPM with 100% coverage and 194 picosecond timing resolution, and lot of patents are there in terms of the axial FOV extension. So same cover, nothing needs to be changed. You can just extend the FOV. The 194 picosecond is a very big barrier. It increases your improvement in signal to noise ratio to a huge extent. Earlier, what we used to achieve was a precision of about 6 to 8 centimeter. This comes to about 2 centimeters with less than 200 picosecond. The improvement or gain in TOF below 200, we are able to get very high volumetric resolution with 2.76 into 2.76 mm crystal elements. The volumetric resolution is 24 mm. As compared to any other OEM, everyone is trying to reduce their crystal size. If you see, in analog, the crystal size used to be 4.6 into 4.6 or 5 mm, 5 mm. Now, every manufacturer has gone to sub 4 mm, trying to come closer and closer. We have gone to sub 3 mm, 2.76 into 2.76, which gives a very high volumetric resolution, which will finally allow you to detect very, very small lesions, having very less partial volume effect. So you will be able to better differentiate malignancy with benign tumors. Here is a comparison of an image of a MRI and a PET. So you can see what we are gaining with the 194 picosecond, and this is a 10-minute brain scan, and see the clarity of the image. It is very, very close to an MR image. So now what we used to suffer earlier in nuclear medicine, we used to have less sensitivity, lesser information, as well as less clarity. The resolution in CT is always 0.2 mm, 0.3 mm, and all, in MR as well, sub mm. Now we are very close to that. So you will see that we will be able to differentiate two pulmonary nodules which are about 2 mm apart. So in this image also you can see a non-TOF and a UMI panorama TOF image. We are able to differentiate two nodules which are 2.3 mm apart due to the volumetric resolution that we are achieving with the small crystals and everything. UMI panorama having 3-bed acquisition with a 35 centimeter as compared to conventional, which we mostly use 6 to 9 beds. And you can see the image quality here as well. So the images acquired in a single FOV, you can most of the time examine the whole thorax at one go, complete head neck at one go, so you don't need to overlap. So any error which might creep in because of image reconstruction will not be there. So having a higher FOV gives you a lot of confidence in terms of reporting where you are not merging the images. A single acquisition gives you the complete information. So in the CT as well, a lot of improvements, 0.2 second to 5 second rotation, finest elements, 1024 matrix, very 60 kVp scans, and as we discussed about the artificial intelligence, United Imaging Artificial Intelligence being a separate company and developing a lot of applications of AI and integrating into all our products, whether it is a PET CT or a CT. So we have iterative reconstruction plus AI both together, and giving you can see on the far right image where AIIR, which is the unique application of United Imaging, is incorporated, and you can see the very sharp images at very, very low dose. A similar dose will yield very grainy images on a non-AIR image. And the metal artifact correction as well as dual energy, I'll not go into deep of that. So all starting from positioning, you have an AI camera which detects the patient. It scans it automatically with a single click. Complete processing is AI based, and the whole workflow processing everything is controlled by AI. So this is the fully integrated, first in the industry, from end to end, from acquisition to processing, having AI at all levels. So you have a U-Vision camera which detects it, the complete FOV. You don't need to position, just position the patient. It will auto-detect the FOV and align, single click, and the patient is scanned. So you can see the difference. Normally you will be taking some time to position. In the panorama, you don't need to do so much. While positioning is being done in other PET CT scanners, here everything is completed till that time. Because automated, no one needs to go inside the scan room. What range you want, the U-Vision camera will do everything. For brain scans where there can be motion, you have a motion correction algorithm where high motion also is corrected and you get very sharp images. Digital self-gating, you don't need to do any gating, automatic gating happens, no bellows belt, nothing required. So all high-end technologies that we would have thought of are inbuilt in it. We have AI-based reconstruction also with deep learning, which is again unique. I'll not go into all of them. Yeah. So this is the most latest and first FDA 510K cleared or FDA cleared AI-empowered iterative reconstruction algorithm. So this has clearly changed the overall image quality that we see in our PET CTs, hyper DPR. So this is a real revolution, and you'll see a significant improvement in terms of image quality with the hyper DPR. And we are the first one to get a 510K for that. So I'll not go deep into it. If anyone wants, we can come to our booth. We have, we'll go through the whole presentation. We have a lot of slides on hyper DPR and overall. So this is the overall basic specs: 76 centimeter gantry, 318 kg table weight capacity, 200 centimeter scan range, 35 centimeter to 148 extendable. So from diagnostics to theranostics, we have a lot of images on theranostics, how we are changing or how we are helping. The panorama helps in terms of better managing the theranostics with lesser half-lives and varying half-lives, a lot of image noise, how we are correcting those and all. So a lot of things are there we can discuss in detail. So this is the latest innovation, UMI Panorama, which broke all barriers. So now we'll go to the next unique product that we have. We don't have this product yet in India, but globally there are about 36 installations. And this is a very high-end SPECT CT. This is a digital CZT based SPECT CT with complete 3D imaging. Normally in gamma camera, we are used to 2D imaging, but here the acquisition is 3D. You reconstruct 2D. From normal gamma camera, you have 2D acquisition, you reconstruct 3D. The acquisition is 3D, you reconstruct 2D if you want. But the normal images are 3D images. And you have complete proximity. There are 12 independent digital detectors which come close to the patient or the anatomy you want to scan. If you want to do a cardiac scan, it will align itself, making the heart, keeping the heart at the center. Or if you're doing bone scans, it will keep the whole body at the center. So very high SNR you will achieve when due to the proximity, and auto alignment. Slice CT. There is very high-end CT associated with it, and it will be, most of the scans will be 3 to 4 times faster. So no need of 3-4 rooms as well. So it will help you. The space is very expensive in India, and the pace with which India is growing, space will become even more precious. So instead of 2-3 gamma cameras, you have one digital SPECT CT. It might not be of lot of value where you have a single gamma camera and the case loads are low, but this is suitable for very high volume centers where you have 2 to 3 gamma cameras. So the viability as well comes in, because it is cost-wise also twice. So you are able to do 3 to 4 times the patients that you do on a normal gamma camera. So 3D total body scan, it covers 200 centimeter. So this kind of CZT based SPECT CT was first launched by Spectrum Dynamics. Now there is one more OEM. In the last 2 years they have launched, but there are a lot of differentiators, a lot of things which in terms of FOV as well as energy range as well as overall capability that Spectrum Dynamics differentiates in terms of overall sensitivity, resolution. So as I said, 16 and 64 slice CT, complete, all applications can be done. It's a complete 3D imaging and integrated workstation. So the technology used is a broad view technology where you cover the full FOV. There are 12 complete digital detectors with swivel motion and collimators inbuilt. So 6 bed positions, you can complete the exam. 32 centimeter is the overall coverage. Complete 2 meters can be covered. So all size of patients can be scanned with the 80 centimeter FOV, 64 slice CT, and complete attenuation correction inbuilt, a very high end diagnostic CT. Iterative reconstruction, integrated workstation, console, everything. So please feel free to come to our booth to have a detailed discussion. I'll not go deep into it right now. We don't have that much liberty of time. But now it's the time. We feel that we should have some digital SPECT CTs in India. Right now, India overall doesn't have a digital SPECT CT. We have moved from analog to digital in terms of PET. 2 years back, India had 5 digital PETs. Now already about 35 to 40 are there. There are 30-40 orders, including all vendors. So we have clearly moved to digital PET, and even leading institutes will be floating tenders with the digital PET. So that transformation has happened. But now it's the time, at least for the high volume centers, to shift to a SPECT CT also, which is digital, so that we are not left behind in terms of technology. So it covers all applications from cardiovascular to neurology, lung, total body, endocrine. So all corrections, everything is there. So we'll not go deep into it right now. Thank you. Dedicated PET. Yeah, digital PET, we are competitive. Yeah. So we have 8 models of digital PET now. Yes, sir. Yes, sir. Yeah. Yeah. Yeah.
So the other request is, can you use AI to achieve that where is the line of annihilation is occurring and improve the 2 millimeter, below 2 millimeter resolution? One. The second is, you are propagating our neighbors and stroke enemies equipments. Can they be manufactured in India and the cost of the production will be, the taxes and everything will go down? So it will be a win-win for both the Medica Bazaar and United Imaging.
So I take both as suggestions, sir. So first one also is a challenge for imaging as such. So and overall PET. So that I will put forth with our R&D team as a suggestion that how we can do it and what if we are doing something. And on the second also, we are very serious to start manufacturing, and our chairman, Dr. Shemin, wants to do grounds up full manufacturing. We had a discussion, we said, why don't you manufacture, or at least you manufacture 20 to 35% components in India. He said, I will not manufacture 25, we will manufacture more than 75. So it will be a full manufacturing, not assembling. So the plan is there.
The order issue will go down and
Yes,
you
sir.
can sell more in government organization. Which we are not able to do it right now because of this government of India's restriction. And we are all selling in private. So the government organizations are getting deprived of this benefit.
Yes, sir. So on this, sir, there is an amendment on the rules last June, where a secretary level person can take a decision and just intimate DPIT. Now no permission needed, sir.
Secretaries do not take any decision. It is the bosses who take the decision.
Correct, sir. So that's update. But certainly on the manufacturing, sir, we have clear plans to have a full-blown manufacturing, and UIH is very, very serious on that. And we look forward to having it soon. We already have had few discussions with government of Tamil Nadu. I was also present in that with Andhra Pradesh and few more governments to identify places and for the factory. So few of them I was also involved. So we.
You go to Bhubaneswar, the government of Odisha is offering you hundreds of acres of land free of cost.
Sure, sir. Let's explore.
Can help you in that.
Yeah. Any questions, Dr. Rajesh, Dr. Santara?
No, thank you, Amit. It's a nice product, but only issue was that being in the government setup, we do not have access to this.
Yeah.
So as sir said, you should install one factory here, manufacture here, and make it make in India then maybe we people who are in the government setup will be able to procure this.
Sure, sir. We are in that path.
That's a very strong suggestion to you.
Yeah, yeah. And right now you have Spectrum products and ACSI also, sir. That
I know ACSI also is there. ACSI, no issue with that.
Yeah, yeah.
But definitely this one looks much attractive.
Thank you, sir.
Please do something, okay?
Sure, sir.
Thank you.
Thank you. Thank you, everyone.
Thank you, sir, for showing a better future of nuclear medicine with a better spatial resolution, I guess. And now I would like to call upon stage the next speaker for the session, Dr. Gil Kowalski. He is the Global Clinical and AI Leader, GE Healthcare. Welcome, sir.
So thank you and good morning. Thank you for the opportunity to discuss to you today. My name is Gil Kowalski. I'm the Global Clinical Application and AI Leader for GE. Been around for 25 years in the molecular imaging domain, always around clinical and scientific and technological aspects. And I'll talk to you today about the digital PET-CT, next generation of digital PET-CT for GE. And I thought that before stepping into the platform itself, let's just take a quick look at what we have today on our portfolio. So familiar with the GE DIQ scanner with gums with 10, 15, 20, 25 centimeter. This is analogic detector. Let me see if my pointer works here. It doesn't go to the screen. Do you have a pointer, maybe? That would help me. This one? Oh, that's perfect. Okay, and then we have the Discover MI, LYSO, and then we have the Omni Legend. This is the one that I will speak to you today about, introduce. We already have the 16 centimeter and the 32 centimeter, and we're planning to take it all the way to a total body of 128. You know, when we came about and thinking about what's going to be our next platform, we were thinking of, okay, what challenges we want to solve. And then we say, well, in order to know the challenges, let's see what the trends are. And clearly we see that a big increase in procedure volume coming up our way. And I'm sure that you see it on the daily basis, either on the oncology, neurology, and the cardiology. So therefore, when we were thinking about the new design, we had to put out a system which really ready for the growth that is coming. The one that can take the lows, those to the lower limits, and also something that investors scale it further to the next generation. And this is how we came about with the Omni Legend. And before I go into the inside of the Omni Legend, I'll share with you a couple images that can illustrate what the performance from clinical perspective it could bring. We were able to do the medical evaluation comparing the DMI 25 ring, and therefore we're able to do the scan and rescan of the patients. And this is a patient that was scanned on the DMI and then was scanned on the Omni. We kept the acquisition time per bed similar, so therefore we can match them. And because of the axial field of view of the 32 is greater than the 25, we will end up with the 10 minutes for the DMI, while 8 minutes for the Omni. As you can see, image quality is great. The uniformity in the liver is improved. Background is reduced with regard to noise. Very nice strip, and a conspicuity of the images is great. And this is kind of outlined the performance of the system. When we started with our initial evaluators and customers over the world, this is coming from Japan, and they started with an acquisition of 15 minutes, and the image quality was great. They were really happy with the image, and then they say, well, why won't we go lower? And then the next scan was with an 8-minute acquisition. They still have a 3.5 megabecquerel, which is quite high, and image quality was also great. And they said, wow, why can it take it further lower? And they tried with the 4 minutes, and with the 4 minutes also the image quality is superb. And this is what we see with our customers these days. They use the whole body acquisition for between 4 to 8 minutes, and they escalate and look at the activity, and this is what you will find in most of customers using it today. Now, what about BMI patients? So this patient is with a high BMI, 49 BMI, and you can appreciate the image quality coming even for such a BMI patient, 295 megabecquerels per kilo. And this is an 8-minute acquisition, only 8-minute acquisition for BMI of a 49 patient. And this is what about PSMA? So this is a PSMA scan again. 8-minute acquisition, very nice separation in the prostate bed, and really illustrates the strengths of this system. want to spend a minute talk about motion-free technology that we have. You know, respiratory artifacts are something that we want to get rid of and see how we can remove it. The motion-free is a deviceless technique where basically we use the quiescent phase in order to remove these artifacts that you see here due to respiration. And therefore being able, without any device, being able to reduce them. And again, this is an 8-minute acquisition motion-free coming with the Omni Legend. And this is the performance that you would expect with this system. How about cardiac? This is a normal scan, 25 millicurie of rubidium injection, high ejection fractions, nice flow for this patient, very nice input functions. And when we look at the additional patient abnormal scan, very low ejection fraction and also flows, but very nice input function and image quality is superb for cardiac. Let's take a look at a brain image, and this brain image again with a great resolution in cortical area, specifically on the sagittal images, will really illustrate the strength of this product. Now, what about adoption? You know, we started to sell this system just this year. So in 9 months, we have more than 200 orders. This became the bestseller of GE products ever around the world. And you can see there is the US, Europe, Japan, Australia. Hopefully we get more dots in this coming in this region in the coming years. And when we look about our initial evaluators, we're happy to see that basically they said what we wanted, we hope from the system. So with reduction of dose, increase of the throughput, image quality is a state of the art, and also the scalability of the system, it's really appreciated. So the design of the system and what we actually hear from the customers really match. Now, when I talk about what's behind the system, I will divide it into the detection. We'll discuss about the precision DL, which is the reconstruction, the workflow, and also the scalability option. So with this, when we came up to look at the challenges, we wanted to see the BGO and the resolution of the silicon photomultipliers to become the digital BGO system. And this digital BGO system, basically, when you think about the BGO, when you compare 20 millimeter LYSO to 20 millimeter BGO, you have 28% more of stopping power due to the atomic number. And now you not only have a 20 centimeter, you have a 30 centimeter. So there is another 47% increase in sensitivity. Overall, 75% increase of sensitivity to get it to 46 CPS per kilobecquerel. I mean, this is the largest that you will see in the market for this category by far. How about energy resolution? So with energy resolution, due to the silicon photomirrors and the number of photons we'll be able to collect, the resolution of the energy resolution was reduced to sub 10%. So we are in the LYSO range. So basically, we're gaining the sensitivity, we're having the good energy resolution. How about spatial resolution?